Good morning, respected teachers, batchmates, and juniors. Today I am going to present my seminar topic on myeloproliferative disorders. Here is today's presentation at a glance. We'll begin with the introduction. So, what basically are myeloproliferative disorders? Myeloproliferative disorders, commonly called myeloproliferative neoplasms, are diseases of the bone marrow and blood. They can strike at any age, have no known cause apart from genetic mutations, and a wide range of symptoms and outlooks. They are a group of clonal neoplastic stem cell disorders characterized by overproduction of mature white cells, red cells, or platelets, suggesting that there is less maturation arrest and more of clonal expansion of terminally differentiated myeloid cells. So let us try to get a basic idea of the pathogenesis behind the myeloproliferative neoplasms. We can see that normally what happens is there is a normal pool of hematopoietic stem cells, which these stem cells further undergo polyclonal hematopoiesis. That is, each stem cell gives rise to various colonies or various series of progenitor cells, for example, erythroid or myeloid or lymphoid progenitors. But if there is a mutation, but firstly let us consider a non-phenotypic mutation. That means where there is a mutation in the genotype but no phenotypic no phenotypic outcome is seen. Therefore, in case of these non-phenotypic mutations, there will be monoclonal hematopoiesis, but not to the extent that it may suppress the polyclonal hematopoiesis of the other normal hematopoietic stem cells. Then we come to the case of a phenotypic mutation where the genetic mutation leads to a phenotypic mutation which can be seen, which causes symptomatic disease. Here we see that there is overproduction of terminally differentiated myeloid cells. But even till this point, some amount of normal polyclonal hematopoiesis is still going on, and this is along with overproduction of terminally differentiated myeloid cells also. Lastly, the most severe form is leukemic mutations, where we can see that the amount of overproduction of the mutated clones is so much that there is suppression of other hematopoiesis, other lineage of hematopoiesis. Therefore, normal polyclonal hematopoiesis is hampered, and this picture is known as leukemias. So, how then do we find why the term leukemia is being used while we are discussing myeloproliferative neoplasms? To understand this, we have to understand that myeloproliferative neoplasms are a type of myeloid neoplasm. This is a broader term. The myeloid neoplasm, it is a broader term which is a heterogeneous group of neoplasms originating from hematopoietic progenitor cells. Myeloid neoplasms primarily involve the marrow and to a lesser degree the secondary hematopoietic organs, that is spleen, liver, and lymph node, and usually present with symptoms related to altered hematopoiesis. And they include acute myeloid leukemias, in which an accumulation of immature myeloid forms, specifically blasts in the bone marrow, suppresses normal hematopoiesis. Then it includes myelodysplastic syndromes, in which defective maturation of myeloid progenitors gives rise to ineffective hematopoiesis leading to cytopenias. And lastly, we have the topic of our seminar today, that is myeloproliferative disorders, in which there is usually increased production of one or more types of blood cells. As we can see here in the WHO classification of tumors of hematopoietic and lymphoid tissue, the latest 2016 edition, we can see that here in this red box, these are the myeloproliferative neoplasms, which include chronic myeloid leukemia, BCR, ABL1 positive, chronic neutrophilic leukemia, polycythemia vera, primary myelofibrosis, essential thrombocythemia, chronic eosinophilic leukemia not otherwise specified, and myeloproliferative neoplasm unclassifiable. And also there is another criteria which we see here, that is myelodysplastic slash myeloproliferative neoplasms. That is, these are entities which are showing both myeloproliferative and myelodysplastic, or a combination of these symptoms, these pictures in their entity. These are the chronic myelomonocytic leukemia, the atypical chronic myeloid leukemia BCR ABL1 negative, the juvenile myelomonocytic leukemia, the myelodysplastic or myeloproliferative neoplasm with ring sideroblast and thrombocytosis, and lastly, myelodysplastic myeloproliferative neoplasm unclassifiable. Also, I would like to bring to your attention, as already discussed, is that acute leukemias are a completely separate entity, whereas the chronic leukemias are under myeloproliferative neoplasm and myelodysplastic slash myeloproliferative neoplasm. Another thing to bring to attention is that mastocytosis, which was a part of the 2008 classification and categorized under myeloproliferative neoplasm, has now been categorized as a completely separate entity in the 2016 classification. Therefore, chronic myeloid leukemias are classified under myeloproliferative neoplasm, but acute myeloid leukemias are considered a separate entity due to vastly different clinico-pathological presentation. A summary is given in the picture below, where we can see that the myeloproliferative neoplasms are characterized by increased mature appearing cells, less fulminant clinical course than AML in many instances, and variable risk of transformation to AML. Myelodysplastic syndrome, on the other hand, are characterized by decreased circulating peripheral blood cells, abnormal differentiation of blood cells in the marrow, less fulminant clinical course than AML, and again variable risk of transformation to AML. Lastly, we have the acute myeloid leukemias, which are having again decreased circulating mature peripheral. We have the acute myeloid leukemia, which is having decreased circulating mature peripheral blood cells, which is in contrast to myeloid dysplastic syndrome. Then there is presence of immature cells in the bone marrow and or periphery, which is once again in contrast to myeloproliferative syndromes. And lastly, it is having a fulminant clinical course, almost invariably lethal without therapy. And this is once again in contrast to both myeloproliferative and myelodysplastic syndromes. So all of them are clonal disorders of hematopoiesis, but they are having different clinical pathologic picture and all are classified as myeloid neoplasms. So lastly, we'll also take a look at the 2008 versus 2016 WHO classification of myeloproliferative neoplasms. We can see that the most important and only difference is that mastocytosis, which was earlier considered as under the category of myeloproliferative neoplasm, is no longer now considered as a category of myeloproliferative neoplasm. It is considered as a separate entity. Mastocytosis or mast cell disease. It is a unique disease amongst hematopoietic neoplasms regarding clinical presentations, molecular findings, cytomorphological characteristics, and immunophenotypical features of neoplastic mast cells. It is a clonal neoplastic proliferation of mast cells that accumulate in one or more organ systems. It is characterized by the presence of multifocal compact clusters of cohesive aggregates or infiltrates of abnormal mast cells. Compared to the previous edition of 2008, mastocytosis has been removed from the category of myeloproliferative disorders in the 2016 WHO classification because of its unique clinical and pathologic features that make it a separate entity. Therefore, let us finally begin with the discussion proper of myeloproliferative disorders. And as already said, it includes these entities. We'll begin with one more concept we need to look at is that in most of these disorders, there is a variable degree of myeloid, erythroid, and megakaryocytic hyperplasia with predominance of one series, resulting in overproduction of white cells in chronic myeloid leukemia, red cells in polycythemia vera, and platelets in essential thrombocythemia. Fibrosis in myeloproliferative neoplasms is because of various growth factors produced by platelets and megakaryocytes, CML and polycythemia vera, and sometimes in essential Thrombocythemia may progress onto myelofibrosis, which in turn may terminate into acute leukemia or marrow failure. Another thing we need to understand is that the myeloproliferative neoplasms are again classified based on whether or not BCR-ABL1 mutation is there. Therefore, the BCR-ABL1 positive myeloproliferative neoplasm includes only CML, whereas the BCR-ABL1 negative myeloproliferative neoplasms includes polycythemia vera, essential thrombocytopenia, primary myelofibrosis, and the mutations that do cause polycythemia vera, essential thrombocythemia, and primary myelofibrosis have been listed here. As we can see, JAK2 exon 12 mutation causes polycythemia vera, and JAK2 mutation is actually causing essential thrombocythemia and primary myelofibrosis. Also, CALR mutation is causing essential thrombocythemia and primary myelofibrosis, along with MPL mutation also. So let us now begin with discussion of each of the headings under this category. Firstly, we have chronic myeloid leukemia. So we'll begin with the subheading proper, that is chronic myeloid leukemia, BCR-ABL1 positive. WHO definition: chronic myeloid leukemia, BCR-ABL1 positive, is a myeloproliferative neoplasm in which granulocytes are the major proliferative component. It arises in a hematopoietic stem cell and is characterized by the chromosomal translocation of from 9 to 22, which results in formation of the Philadelphia chromosome containing the BCR-ABL1 fusion gene. In CML, BCR-ABL1 is found in all myeloid lineages and in some lymphoid and endothelial cells. Nearly 95% of CML patients demonstrate Philadelphia chromosome in the metaphase in cells of myeloid, erythroid, megakaryocytic, and lymphoid series, suggesting that the origin of CML is from a stem cell. Philadelphia chromosome is a reciprocal translocation between chromosomes 9 and 22. As we can see in this picture here, for the formation of the Philadelphia chromosome, there is a reciprocal transfer of genetic material between the chromosome 9 and chromosome 22. BCR-ABL fusion gene is formed by 5' BCR of chromosome 22 and ABL translocated from chromosome 9 to chromosome 22, as we can see here. The reciprocal 3' BCR-ABL formed on chromosome 9, as we can see here, does not play any role in pathogenesis. The BCR-ABL encoded tyrosine kinase has the properties of an oncogenic growth factor, resulting in proliferation of white cells. Three major mechanisms involved in pathogenesis are altered adhesion of proliferating leukemic cells to bone marrow stroma, activation of mitotic signaling, reduced apoptosis. All three mechanisms result in uncontrolled, unhindered proliferation, resulting in leukemia. The FAB group has classified CML into three subtypes. First is the chronic granulocytic leukemia. This is the classical CML with Philadelphia chromosome or Philadelphia negative chromosome but BCR-ABL1 fusion positive. The second type, and this first type that we discussed, is the one that is classified under myeloproliferative neoplasms. The second type is atypical CML. This is the Philadelphia negative disease with monocytosis intermediate between classical CML and chronic myelomonocytic leukemia, with prominent dysplasia of granulocytic and megakaryocytic or erythroid series in MDS/MPN category. And as we have already discussed earlier, that the atypical CML is classified under the myelodysplastic/myeloproliferative neoplasm category. And lastly, we have the chronic myelomonocytic leukemia. This is the Philadelphia negative leukemia with prominence of monocytes in the peripheral blood. This entity has been placed under myelodysplastic/myeloproliferative neoplasm category. As we can see in the picture below, if we consider it to be a spectrum, on one end is the chronic granulocytic leukemia and on the other end of the spectrum is myelomonocytic leukemia, with atypical chronic myeloid leukemia showing us intermediate features, that is monocytes in between 3 to 10%. Sorry. Clinical features. Most patients with CML are diagnosed in chronic phase, which usually has an insidious onset. Nearly 50% of newly diagnosed cases are asymptomatic and discovered when a white blood cell count performed as part of a routine medical examination is found to be abnormal. Common findings at presentation include fatigue, malaise, weight loss, night sweats, and anemia, and about 50% of patients have palpable splenomegaly. So when we are discussing about clinical features, we have to discuss about the phases also. First up is chronic phase. Clinical presentation of the patient is usually in the 40 to 60 years age group, that is 80%, and onset of symptoms is insidious with fever, sweats, weight loss, and fatigue, and feeling of a full abdomen. As we can see here, enumeration of the clinical features of chronic phase of CML shows us splenomegaly, weight loss, terminal tenderness, easy bruising, fatigue, fever, hepatomegaly, lymphadenopathy, all are features of chronic phase of CML. As we can see in the picture below, part A of the photo is showing splenomegaly in chronic myeloid leukemia. The gross appearance of the spleen is solid and uniformly deep red, although areas of infarction are appearing as lighter colored regions. The photo B is showing us the distribution of the red pulp of the infiltrate, and it usually compresses and obliterates the white pulp. And lastly, the C picture is showing us the leukemic cells which are present in the splenic cords and sinuses. In this picture, we can see that the cells are shifted towards the immature forms. So now let us discuss the peripheral blood findings of chronic phase. Leukocytosis. There is marked leukocytosis with TLC ranging from 13 to the power 9 per liter to 500 to 10 to the power 9 per liter, mainly neutrophilic, and all stages from myeloblast to neutrophil can be seen. Another phenomenon we see is myelocyte bulge, which is characterized by 20 to 40% of the white cells being myelocytes, and it is the major immature cell in the blood. As we can see in the first picture here, myelocyte bulge has been indicated. All the black arrows are indicating myelocyte. Myelocyte bulge is a characteristic feature in Philadelphia positive untreated CML. Next feature is basophilia. Absolute basophilia is of critical importance, and in many cases it even precedes the manifested CML. As we can see in the second picture here, two basophils have been marked, and they are seen in the peripheral blood smear. Basophils are smaller than the neutrophils, and the nucleus is covered by basophilic granules. Next up are the RBCs. Majority of the patients have normocytic normochromic anemia and nucleated RBCs, that is 1 to 10 per 100 RBCs. Some with nuclear budding are present in majority of the patients. We can see in the first picture here that the red cells demonstrate anisopocytosis with target cells and hypochromia. But usually in CML, red cells are normocytic normochromic. Lastly, we have platelets. Thrombocytosis varies from 300 to 1000 into 10 to the power 9 per liter in large number of cases. We can see here in the second picture, first part of the second picture, we can see that there is variation in platelet size with few giant platelets and a naked megakaryocytic nucleus. In the B picture, we can see the peripheral blood film demonstrates a giant agranular platelet. Bone marrow findings. We will first see is myelopoiesis. Bone marrow is markedly hypercellular with replacement of fat by plastic hemopoietic cells with marked myeloid hyperplasia, and the ME ratio is elevated to 15:1 to 49:1. Megakaryocytes demonstrate hyperplasia with focal clustering. Megakaryocytes are smaller dwarf forms, that is can be seen, and they are smaller than the normal megakaryocytes. And erythropoiesis, we see that erythropoiesis is decreased and is morphologically normal. In some cases, erythroid cells are increased, though the ME ratio remains high. As we can see in the photo here, for chronic myeloid leukemia, BCR ABL1 positive, we can see here that the peripheral blood smear showing leukocytosis and neutrophil cells at various stages of maturation. Basophilia is prominent and no dysplasia is present. In the B picture, we are seeing that the bone marrow biopsy is showing marked hypercellularity due to granulocytic proliferation. And in the C picture, we can see that the megakaryocytes in CML are characteristically smaller than normal megakaryocytes. In the D picture, we can see that the bone marrow aspirate smear shows expansion and maturation of the neutrophil lineage, increased basophils, and a small dwarf megakaryocyte is also seen, which is smaller than a normal megakaryocyte. Another thing we need to consider is pseudo-Gaucher cells or C-blue histiocytes. Scattered amongst the marrow cells are macrophages with linear striations or granular cytoplasm, which are known as pseudo-Gaucher cells. Some with sea-blue colored granules resembling sea-blue histiocytes. Increased lipid turnover from granulocytic membranes results in accumulation of these macrophages. As seen in this photograph, the A photomicrograph here is showing morphological variability in the initial bone marrow biopsy specimen of patients with CML. In the photo, we are seeing prominent increase in the number of dwarf megakaryocytes that are dispersed throughout the marrow. In the B picture, we are seeing reticulin fibrosis of variable degree. In the C picture here, we are seeing pseudo-Gaucher cells. The pseudo-Gaucher cells are commonly observed in the marrow aspirates of patients with CML. And again, in the D picture, we are seeing the foamy or striated cells in bone marrow biopsy sections. These histiocytes are secondary to increased cell turnover, are derived from the neoplastic clone, and are easily distinguished from the dwarf megakaryocyte, seen, one of which can be seen in the lower middle margin of the D photograph. Transformation of CML. CML usually transforms to an accelerated phase after 2 to 5 years of disease, which may further progress to a blastic phase. The accelerated phase of CML, these are the cases of CML in which the blasts are less than 20%, usually in the range of 10 to 19%. The diagnosis of CML, the accelerated phase, could be made if any of the following parameters is present. The photo below here is showing us the criteria for accelerated phase of CML as per 2016 WHO criteria. We have that we need any one or more of the following hematologic or cytogenetic criteria we need, or we need response to the TKI criteria. So what are the hematologic and cytogenetic criteria? We need persistent or increasing WBC unresponsive to therapy, that is more than 10 into 10 to the power 9 per liter. We need persistent or increasing splenomegaly unresponsive to therapy. We need persistent thrombocytosis unresponsive to therapy. We need persistent thrombocytopenia unrelated to therapy. 20% or more basophils in the peripheral blood, 10 to 19% blasts in peripheral blood and or bone marrow. Additional clonal chromosomal abnormalities in Philadelphia cells at diagnosis that include major root abnormalities, that is second Philadelphia chromosome, trisomy 8, isochrome 17q, trisomy 19, etc. And lastly, any new clonal chromosomal abnormality in Philadelphia cells that occurs during therapy. Either one of this, or on the other side, we can see provisional response to TKI criteria, that is tyrosine kinase inhibitor criteria. Hematologic resistance to the first TKI for failure to achieve complete hematologic response to the first TKI, or any hematological, cytogenetic, or molecular indications of resistance to 2 sequential TKIs, or occurrence of 2 or more mutations in BCR-ABL1 during TKI therapy. So now that we have seen the criteria for accelerated phase, let us see the blood picture. In CML accelerated phase, the first picture here, picture A, is showing peripheral blood film with increased number of basophils with myeloid precursors. And the B picture is showing us increased blast cells, 3 of which are shown, which have been indicated in this picture, and the differential leukocyte count was showing 15% blast cells. In the second photo, picture A is showing us a bone marrow biopsy specimen showing areas of cellular depletion and prominence of small megakaryocytes. The swirling appearance of the cells is caused by an increase in underlying reticulin fibers. So the B picture is showing us basophils accounting for more than 20% of the WBCs, and C picture is showing us increase in blasts, which is appreciated with CD34. Lastly, we have the blastic phase. As the chronic phase transforms to the terminal phase of blast crisis in about 70% of the cases, the blast cells in peripheral blood or bone marrow, they increase to more than 20% with anemia and thrombocytopenia. Clinical course is similar to that of acute leukemia de novo or is slower. Blastic phase in 60 to 70% of the cases is myeloid, but cytochemical MPO staining is weakly positive or negative, with the subtype being M1, M2, M4, M5, M6, or M7. Therefore, confirmation of myeloid nature should be done using flow cytometric analysis using cytoplasmic MPO instead of cytoplasmic MPO. WHO criteria for diagnosis of CML blastic phase are blast more than 20%, extramedullary blast proliferation which may occur in skin, lymph nodes, spleen, bone, or central nervous system, large foci of blasts in bone marrow biopsy, or entire intertrabecular region even if the remainder biopsy shows chronic phase. CD34 and TDT-IHC should be carried out to confirm their blastic nature and differentiate from promyelocyte or myelocyte, which are normally present in paratrabecular areas. As we can see in these photomicrographs here, picture A is showing us the peripheral blood smear. Most of the white cells are blasts. The B and C photomicrographs are showing us sheets of blasts in the bone marrow. And lastly, the D picture is showing us myeloperoxidase immunohistochemistry, proving the myeloid origin of the blasts. Again, we have here the flow cytometry. We can see in the first one that in the CD45 SS gating flow cytometry, we can see the red patch is showing us blasts, the blue patch is showing us lymphocytes, and the pink patch is showing us immature granulocytes. Afterwards, when we do flow cytometry, we are seeing that the blasts are positive for CD33 HLA-DR, as we can see here. Then we can also see that it is positive for CD34 and CD13, and here we can see it is again positive for CD13 but not for CD19. So, and again in case of CD7, we can see there is dim expression, that is only 36% blasts indicate, and therefore this indicates an aberrant expression of CD7. But mostly it is showing us myeloid lineage. Now, another thing we need to discuss is that nearly 20 to 30% of the cases undergo lymphoblastic blast crisis, which are CD10, TDT, and CD19 positive, with aberrant expression of myeloid antigens. So as we saw in the previous flow cytometry here, this was CD19 negative. But for lymphoid blasts, there will be CD10 and CD19 positive with aberrant expression with some showing aberrant expression. All cases of blastic phase or accelerated phase should be screened by flow cytometry to rule out lymphoblasts because it is highly indicative of impending blast crisis. If we take a look at the picture below, picture A is showing us peripheral blood smear with numerous lymphoid morphology blasts among leukemic myelocytes, and picture B is showing us bone marrow biopsy of the same case. The picture C is showing us the marrow aspirate smear. And here by flow cytometry, we can see that they are CD10 and CD19 positive, as we can see here, CD10 and CD19 positive there, but they are CD33 negative and also CD13 negative, which proves they are of lymphoid origin. So now that we have finished discussing CML, we will discuss the rest of the BCR-ABL1 negative myeloproliferative neoplasms. This group of disorders is comprised of polycythemia vera, essential thrombocythemia, and primary myelofibrosis. One thing common in all of them is that all share an activating mutation of tyrosine kinase, JAK2, indicating that these entities are really distinct. The JAK2 mutation, valine to phenylalanine substitution, is seen in 90% to 95% of polycythemia vera and 60% of essential thrombocythemia and 65% of primary myelofibrosis. The mutation results in constitutive activity of JAK2 tyrosine kinase similar to the translocation associated overactivity of ABL tyrosine kinase in CML and PDGFR tyrosine kinase in chronic eosinophilic leukemia. The group includes the following: polycythemia vera, essential thrombocythemia, primary myelofibrosis, chronic eosinophilic leukemia, myeloproliferative neoplasm, unclassifiable, and chronic neutrophilic leukemia. So let us first discuss chronic neutrophilic leukemia. The WHO criteria says, WHO definition says, chronic neutrophilic leukemia is a rare myeloproliferative neoplasm characterized by sustained peripheral blood neutrophilia, bone marrow hypercellularity due to neutrophilic granulocyte proliferation, and hepatosplenomegaly. There is no Philadelphia chromosome or BCR-ABL1 fusion gene. The diagnosis requires exclusion of reactive neutrophilia and other myeloproliferative and myelodysplastic or myeloproliferative neoplasm. The peripheral blood shows marked neutrophilia with fewer metamyelocytes and myelocytes. The immature granulocytes, promyelocytes, myelocytes, and metamyelocytes are less than 10%. Blast cells are less than 1%. Total white cell count is more than 25 into 10 to the power 9 liter, and nearly 80% of the cells are neutrophils and band forms without dysplasia. Red blood cell and platelet morphology is normal. Bone marrow demonstrates hypercellularity, and there is myeloid proliferation with ME ratio of 20:1. Clinical features. The most constant clinical feature reported is splenomegaly, which may be symptomatic. Hepatomegaly is usually present as well. There may be bruising and purpura. A history of bleeding from mucocutaneous surfaces or from the gastrointestinal tract is reported in 25 to 30% of cases. Gout and pruritus are other possible features, and serum vitamin B12 and uric acid are often elevated. As we can see in this photomicrograph here, for chronic neutrophilic leukemia, the picture A is showing us characteristic neutrophilia in the peripheral blood smear, and the picture B is showing us toxic granules, which are commonly observed. Picture C is showing us the bone marrow picture, which demonstrates neutrophil proliferation from myelocytes to segmented forms with toxic granulation, but no other significant abnormalities. Picture D is showing us the bone marrow biopsy specimen, which is hypercellular, showing a markedly elevated myeloid to erythroid ratio with increased number of neutrophils in particular mature segmented forms. And lastly, this is the diagnostic criteria as per WHO, which says peripheral white blood cell count should be more than 25 to 10 to the power 9 per liter. There should be segmented neutrophils plus banded neutrophils more than 80%. Neutrophil precursors should constitute less than 10%. Myeloblasts should be rarely observed. Monocyte count should be less than 1 to 10 to the power 9 per liter, and no dysgranulopoiesis. There should be hypercellular bone marrow. Myeloblasts should constitute less than 5%. Neutrophil maturation should appear normal, and should, if it's not meeting WHO criteria for BCR-ABL1 positive chronic myeloid leukemia, polycythemia vera, essential thrombocythemia, or primary myelofibrosis, then it can be considered as a chronic neutrophilic leukemia. And also there should be no rearrangement of PDGFRA, PDGFRB, or FGFR1, and no PCM1 JAK2 fusion. So now let us discuss polycythemia vera. WHO definition says that polycythemia vera is a chronic myeloproliferative neoplasm characterized by increased red blood cell production independent of the mechanisms that normally regulate erythropoiesis. All patients carry the somatic JAK2V617F gain of function mutation or other functionally similar JAK2 mutation that results in proliferation not only of the erythroid lineage but also of granulocytes and megakaryocytes, that is panmyelosis. Generally, two phases of polycythemia vera are recognized. That is a polycythemic phase or overt polycythemic phase, which is associated with elevated hemoglobin level, elevated hematocrit, and increased RBC mass. And then a spent phase or post-polycythemic myelofibrosis phase, in which cytopenias including anemia are associated with ineffective hematopoiesis, bone marrow fibrosis, extramedullary hematopoiesis, and hypersplenism. As we can see in the picture included in this slide, the phases of polycythemia as per WHO 2008, it includes pre-polycythemic phase also, which is characterized by borderline to mild erythrocytosis, episodes of venous or arterial thrombosis, mesenteric or portal splenic vein thrombosis or Budd-Chiari syndrome, and bone marrow should show panmyelosis, increased HB, normocytic non-chromatic cells, neutrophilia, and granulopoiesis should be normal. Clinical features: the disease is insidious in onset and the patient has the disease for a long time before he manifests clinically. It is more common in men than in women, the ratio being 1.5 to 2 is to 1. And it is a disease of the old age, occurring between 55 and 80 years. The median age of diagnosis is 60 years. The increased viscosity and blood volume are responsible for the hypertension or vascular abnormalities caused by the increased RBC mass. Headache, dizziness, visual disturbance, and paresthesias are major symptoms. Pruritus, erythromelalgia, and gout are also common. Plethora and palpable splenomegaly are also seen. Ruddy skin of the face is prominent, especially on lips, tip of nose, and ears. Fingers and toes appear cyanotic. There is history of intense itching due to hyperhistaminemia following warm water bath. Conjunctival redness is marked. Weight loss, sweating, and pruritus are not uncommon. Skin may show dark violet spots or brownish pigmentation. So let us begin with discussing the overt polycythemic phase. Major features in peripheral blood and bone marrow are effective proliferation of erythroid, granulocytic, and megakaryocytic lineages. That is, there is panmyelosis. Therefore, hemoglobin, white cells, and platelets are increased, and there is sustained absolute erythrocytosis. As seen in this WHO criteria, diagnostic criteria included here, the major criteria being elevated hemoglobin concentration above 16.5, elevated hematocrit above 49% in men, bone marrow biopsy showing age-adjusted hypercellularity with trilineage growth, that is panmyelosis, and presence of JAK2 V617F or JAK2 exon 12 mutation, and a minor criteria being subnormal serum erythropoietin level. As we can see in the photos here, we can see picture A is showing us peripheral blood film from a case of polycythemia vera, shows a much darker peripheral blood film in comparison to a normal smear. The picture B is showing us sheets of red cells, and red cells are very close and superimposed because of high RBC count. And picture C is showing us peripheral blood film demonstrating leukocytosis, and the neutrophil alkaline phosphatase score is high. Now in this photomicrograph, we can note that for polycythemia vera, the so-called masked or prodromal presentation or the pre-polycythemic presentation, we have a mildly hypercellular bone marrow showing a predominance of large megakaryocytes in the bone marrow biopsy section, and the picture B is showing us many large and giant hypersegmented essential thrombocythemia-like megakaryocytes in a case clinically mimicking an essential thrombocythemia, because of a platelet count much more than 1000 into 10 to the power 9 per liter. Also, we can note in picture B is that the only mildly increased granulo and erythropoiesis is there. In the second part of of this picture, we can see that overt polycythemic presentation is being shown. The picture A is showing the bone marrow biopsy of overt polycythemic presentation. It is showing characteristically hypercellular marrow, characterizing the panmyelosis. The picture B is showing us megakaryocytes revealing different sizes, which is always the prominent feature. The cells are more easily evaluated by using the periodic acid Schiff staining reaction. The picture C is showing us panmyelosis, that is trilineage proliferation, and and it is being demonstrated by the naphthol ASD chloroacetate, that is CAE stain, which by accurately identifying the granulocytic cells, which is being indicated by the red areas here, it helps in assessment of the relative proportion of the two major lineages, erythropoietic and granulopoietic. At this disease stage, the megakaryocytes show increased pleomorphism with significant differences in size, but no relevant maturation defects such as nuclear cytoplasmic differentiation is noted, as shown with PA staining. And now the third stage we can discuss, that is the post polycythemic myelofibrosis stage. During the later phase of the disease, erythropoiesis progressively decreases and red blood cell mass normalizes and then decreases. The hallmark of this stage is reticulin and collagen fibrosis of the bone marrow. This myelofibrosis leads to extramedullary hematopoiesis in spleen and liver, resulting in splenomegaly and hepatomegaly. This is accompanied by leukoerythroblastic blood picture of nucleated red cells, myelocytes, metamyelocytes, teardrop cells, and poikilocytosis. Blast cells are 10%. As seen in the photomicrograph included below, the polycythemia vera post-polycythemic myelofibrosis stage. A splenectomy specimen here is showing splenic enlargement in the post-polycythemic phase, and it is mainly due to extramedullary hematopoiesis that occurs in the splenic sinuses, as well as fibrosis and entrapment of platelets and hematopoietic cells in the splenic cords. On the other side, we have the diagnostic criteria by WHO, which says required criteria is documentation of a previous diagnosis of WHO-defined PV and bone marrow fibrosis of grade 2 to 3 on a 0 to 3 scale, or grade 3 to 4 on a 0 to 4 scale. Additional criteria, at least two of which are required, state that anemia or cytoreductive treatment for erythrocytosis history should be there. Leukoerythroblastosis should be there. Increasing splenomegaly defined as either an increase in palpable splenomegaly of more than 5 cm from baseline. And last criteria is development of any two of the following constitutional symptoms, being more than 10% weight loss in 6 months, night sweats, or unexplained fever. In this photomicrograph, picture A is showing us peripheral blood smear with leukoerythroblastosis and numerous teardrop-shaped red blood cells. Picture B is showing us bone marrow biopsy with conspicuously abnormal megakaryocytic proliferation and depletion of the erythroid and granulocytic cells. Picture C is showing us immunostaining for CD61, which illustrates the atypia of the megakaryocytic population, including a population of small immature megakaryocytes. And lastly, picture D is showing us overt reticulin fibrosis that is invariably present in post polycythemic myelofibrosis with myeloid metaplasia. Now we can discuss primary myelofibrosis. Let us look at the WHO definition. Primary myelofibrosis is a clonal myeloproliferative neoplasm characterized by a proliferation of predominantly abnormal megakaryocytes and granulocytes in the bone marrow, which in fully developed disease is associated with reactive deposition of fibrous connective tissue and with extramedullary hematopoiesis. There is a stepwise evolution from an initial prefibrotic or early stage characterized by hypercellular bone marrow with absent or minimal reticulin fibrosis to an overt fibrotic stage with marked reticulin or collagen fibrosis in the bone marrow and often osteosclerosis. The fibrotic stage of PMF is clinically characterized by leukoerythroblastosis in the blood with teardrop-shaped red blood cells, hepatomegaly, and splenomegaly. For primary myelofibrosis, we should also look at the pathogenesis. It is a progressive MPN arising from pluripotent hematopoietic progenitor cell characterized by clonal granulocytic and megakaryocytic proliferation associated with reactive marrow fibrosis. The progressive marrow fibrosis may lead to marrow failure or transformation to AML. The fibroblasts are polyclonal and they secrete collagen in response to cytokines secreted by megakaryocytes. Transforming growth factor and platelets-derived growth factor are the main mediators of collagen deposition in the marrow. As we can see here in this flowchart, the JAK2V617F, CALR, and MPL and other mutations lead to neutrophil and platelet activation. This leads to stimulation of megakaryocytes and monocytes. Another thing that leads to the stimulation is stimuli for secondary myelofibrosis. All of this leads to PDGF, TGF-beta, and BFGF secretion. This leads to increased marrow-stroma and therefore marrow fibrosis. Stimulation of the megakaryocyte also leads to stromal cells of the marrow being activated due to hematopoietic clonal development and proliferation, which is also caused by JAK2 mutation. This again leads to stromal cell abnormal hematopoietic cell interactions. This causes mediators to be released, and again this causes marrow fibrosis. Clinical features. Primary myelofibrosis is a disease of the middle-aged and elderly patients. Just a minute. Primary myelofibrosis is a disease of the middle-aged and elderly patients. Both sexes are equally affected. Many patients present clinically with weight loss, night sweats, anorexia, fatigue, or lump in the left hypochondrium. Gout and renal colic manifestations are uncommon. Petechiae, ecchymosis, and lymphadenopathy may be present in few patients. Splenomegaly of various degrees is detected in as many as 90% of patients and can be massive. Nearly 50% of patients have hepatomegaly, depending on the stage of disease. So for chronic eosinophilic leukemia not otherwise specified, the WHO definition is chronic eosinophilic leukemia not otherwise specified is a myeloproliferative neoplasm in which an autonomous clonal proliferation of eosinophil precursors results in persistently increased numbers of eosinophils in the peripheral blood, bone marrow, and peripheral tissues, with eosinophilia being the dominant hematological abnormality. Organ damage occurs as a result of leukemic infiltration or of the release of cytokines or other proteins by the eosinophils. In CEL, not otherwise specified, the eosinophil count is approximately 1.5 into 10 to the power 9 per liter in the blood, and there are less than 20% blasts in the peripheral blood and bone marrow. Clinical features. It is eosinophilia is sometimes detected incidentally in patients who are otherwise asymptomatic. In other cases, patients experience constitutional symptoms such as weight loss, night sweats, fever, fatigue, cough, angioedema, muscle pain, pruritus, and diarrhea. The most serious clinical finding relate to endomyocardial fibrosis with ensuing restrictive cardiomegaly. Scarring of the mitral and tricuspid valve leads to valvular regurgitation and the formation of intracardiac thrombi, which can embolize to the brain or elsewhere. Cardiac failure can occur. Peripheral neuropathy, CNS dysfunction, pulmonary symptoms due to lung infiltration, and rheumatological findings are frequent manifestations. Reactive eosinophilia, the set of photomicrographs here is showing us reactive eosinophilia in lymphoblastic leukemia. Picture A is showing us the elevation of the white blood cell count seen in this peripheral blood smear. It is primarily due to the eosinophils with only an occasional lymphoblast. The picture B is showing us lymphoblasts which are clearly appreciable. The second set of photo, picture A, the second set of photo is showing us a chronic eosinophilic leukemia not otherwise specified, where the peripheral blood smear from a patient with a history of persistent eosinophilia is being shown. Immature and mature eosinophils are present. The cytogenetic analysis showed trisomy 10. And the fourth photo here is showing idiopathic hypereosinophilic syndrome. The blood smear from a patient with cardiac failure is being shown here, as we can make out the eosinophils. The diagnostic criteria has been included by WHO, which says that eosinophilia should be more than equal to 1.5 into 10 to the power 9 per liter. WHO criteria for BCR-ABL1 positive chronic myeloid leukemia, polycythemia vera, essential thrombocythemia, primary myelofibrosis, chronic neutrophilic leukemia, chronic myelomonocytic leukemia, and BCR-ABL1 negative atypical chronic myeloid leukemia should not be met. No rearrangements of PDGFRA, PDGFRB, FGFR1 should be there, and there should be no clonal, cytogenetic, or molecular genetic abnormality, and or blast cells account for more than 2% of cells. Also, blast cells should constitute less than 20% of the cells in the peripheral blood and bone marrow. The last topic for today's presentation is myeloproliferative neoplasm, unclassifiable. The WHO definition says the designation of myeloproliferative neoplasm unclassifiable should be applied only to cases that have definite clinical, laboratory, molecular, and morphological features of a myeloproliferative neoplasm, but fail to meet the diagnostic criteria of any of the specific MPN entities, or that's present with features that overlap between two or more of the MPN categories. So most cases of MPN unclassifiable fall into one of the three groups. The first group is a subset of cases with so-called masked or pre-polycythemic presentation of polycythemia vera, pre-fibrotic or early primary myelofibrosis, or early phase essential thrombocythemia, in which the characteristic features are not yet fully developed. A proportion of cases presenting with portal or splanchnic vein thrombosis that fail to meet the diagnostic criteria for any of the specific MPN may be considered to belong in this group. The second group is advanced stage MPN, in which pronounced myelofibrosis, osteosclerosis, and transformation to a more aggressive stage with increased blast counts and or myelodysplastic changes obscures the underlying disorder. And third group is cases with convincing evidence of a myeloproliferative neoplasm, in which coexisting neoplastic or inflammatory disorder obscures some of the usual diagnostic clinical findings. Clinical features are similar to those of other MPNs. In early unclassifiable disease, organomegaly may be minimal or absent, but splenomegaly and hepatomegaly can be massive in advanced cases. The hematological values are also variable, ranging from mild leukocytosis to moderate or marked thrombocytosis with or without accompanying anemia. Prominent cytopenia or myelodysplastic features should always prompt the definitive exclusion of MDS, MPN, and myelodysplastic syndromes. Discrepancies between morphological and clinical features are particularly common in cases presenting with otherwise unexplained portal or splanchnic vein thrombosis. Uh, in the included photomicrographs here, in the first set, we can see picture A is showing us an myeloproliferative neoplasm unclassifiable early stage, the bone marrow specimen of a 50-year-old man with platelet count of 52,000 into 10 to the power 9 per liter is being shown. And he had a hemoglobin concentration of 17 gram per DL for many months. The specimen is showing hypercellularity and increased number of enlarged mature repeating megakaryocytes, a slightly increased number of erythroid precursors, and prominent sinuses filled with erythrocytes, suggesting so-called mass presentation of polycythemia vera. The second picture, that is picture B, is showing his late fibrotic stage at the bone marrow biopsy specimen from a 65-year-old female with leukocytosis, pancytopenia, and marked splenomegaly. Uh, Also, we are seeing fibrosis with osteosclerosis and markedly atypical megakaryocytes. The last photo, the third photo, is showing features simulating myelodysplastic or myeloproliferative neoplasm, unclassifiable. The bone marrow biopsy shows severe dysmegacardiopoiesis. The dysplastic appearance of this case was therapy related and a consequence of hydroxycarbamide administration for late stage polycythemia vera. Lastly, the diagnostic criteria included by WHO for MPN unclassifiable is features of MPN should be present, but WHO criteria for any other MPN should not be met. JAK2, CALR, and MPL mutation characteristically associated with MPN should be there, or presence of another clonal marker should be there, or absence of a cause of reactive fibrosis should be there. Conclusion: the WHO Committee of Hematopathologists, clinicians, and scientists with special interest in MPN has now delivered the most comprehensive and practically useful outline of diagnostic criteria for essential thrombocythemia, polycythemia vera, and primary myelofibrosis. Special attention to morphology is required in order to distinguish essential thrombocythemia from primary myelofibrosis and JK2 mutated essential thrombocythemia from polycythemia vera. Bone marrow examination is also the most optimal method of obtaining cytogenetic information that has been shown to influence survival in both PMF and PV. In the future, we expect an increasing role for other mutations in complementing morphologic diagnosis in myeloproliferative neoplasms and providing additional prognostic information. Summary: myeloproliferative disorders come under the broad heading of myeloid neoplasms. Leukemias are a particular entity which are not considered wholly separate entity, but depending on the clinico-pathological picture, either as a part of myeloproliferative neoplasm or as acute leukemias. Thus, all acute leukemias are categorized separately by WHO, whereas the chronic leukemias based on BCR-ABL status are classified under myeloproliferative or myeloproliferative/myelodysplastic syndromes. The myeloproliferative neoplasms are further divided based on presence or absence of BCR-ABL fusion, and myeloproliferative neoplasms are a heterogeneous group of neoplasms originating from hematopoietic progenitor cells. These are my references. Thank you.